Welcome back. In the last part of today's lecture, we're going to talk about somatostatin receptor scintigraphy, and the this relies on overexpression of somatostatin receptors on many neuroendocrine tumors. And the original molecule that was used for imaging is pentriotide that was labeled with indium 111 to enable the localization with the gamma cameras. The tumors with high expression of somatostatin receptors include adrenal medullary tumors, so these are PHEOs, neuroblastomas, ganglioneuromas, and paragangliomas, although MIBG are preferred for these tumors. The next category is the gastroenteropancreatic neuroendocrine tumors, so this is what we typically call carcinoid, gastrinomas, glucagonomas, and a variety of other tumors. And this is the mainstay of somatostatin receptor imaging. However, also the expression occurs in Merkel cell tumors and pituitary adenomas and small cell lung cancers. Many other tumors can have some expression, however, it tends to be pretty low. Some tumors, such as insulinoma medullary thyroid cancer, can be detected, but again, it tends to be somewhat much more all over the place. Many non-neoplastic processes can have increased uptake. Where I find this to become more confusing, if somatostatin imaging is performed right after surgery, the inflammatory cells that are attracted to the surgical site can easily create a false positive. So the most common molecule that we use is indium 111 pentriotide. It's a standard somatostatin analog. The typical adult dose is 6 millicuries, and part of it is because indium is a terrible molecule. Because it sticks around for so long, we can't push the dose up. Indium is usually cleared fairly rapidly from the blood pool. The excretion is renal, so we will see kidneys, we will see bladder. The biologic half-life for the molecule is about 6 hours. Imaging is typically performed 24 hours after the injection. However, 4 hours can be performed as well if we're quite sure that we know what we're looking at, and 48 hours is always the answer in nuclear medicine. Is whenever we're given a chance to do a delay image, we always do a delayed image. The tracer uptake can be seen in the pituitary gland, thyroid, liver, spleen, kidneys, and occasionally gallbladder. The intestinal activity is not going to be typically present in the 4-hour images, but will be present in the subsequent images because of the biliary excretion route. And this is where we typically use 48-hour images, is to allow the bowel to clear. So this is an example of a triotide scan that shows an innumerable number of lesions throughout the liver, essentially replacing the whole liver. This is another example where we have a planar image, a SPECT image, as well as the CT image showing neuroendocrine tumor metastasis to the liver. And you can see that on the SPECT image, we can see a lot more lesions than we see on a typical planar image, and that's without even using the slices. This is another example where we see a really subtle neuroendocrine tumor. We can see it right here, and this is the lesion on CT. From what I recall, this is one of the pancreatic hormonally active lesions. This is another example where we see carcinoid tumor metastasis. Notice I'm not using the proper terminology, but we see these lesions on CT where, again, it's a mesenteric root mass, somewhat spiculated borders, calcification, and we see the lesions on the triotide scan. And we can see that, it's used pre and after surgery, so we can see the lesions after surgery. We can see fewer, but not the entire excision of all of the lesions after surgery. In the last decade, there has been development of multiple new targeting agents through better small molecule chemistry. The original attempts were to use the antibodies, but the antibodies proved to be terrible targeting agents. The new small molecule chemistry allows chemists to design molecules that target these receptors much more accurately. So we have new SPECT imaging agents, and much more excitingly, we have new PET imaging agents which have proven to be vastly superior to the conventional electrolyte scan with its much higher sensitivity and specificities. So depending on the center, depending on the insurance and on the copays, these may be available to the patients. In our environment, we have tried to get these agents for years with no success because of how much they cost. In summary, we've talked about thyroid scintigraphy, where the only truly appropriate indication is abnormal thyroid function tests, and then we're looking for either no uptake, homogeneously increased uptake, or focal uptake of autonomous nodules. We've talked about system-EB and using it to localize the parathyroid adenomas prior to surgery, although combination with ultrasound works much better, and now many centers are switching to 4D CT, or actually 3-phase CT. We've also talked about the MIBG and its remarkable specificity for adrenal tumors, although certainly can be seen in other endocrine tumors as well, but this is really the mainstay of non-invasive diagnosis of a paraganglioma or pheochromocytoma. We've talked about the ectreotytes, scans of somatostatin receptor targeting agents that have evolved with newly available PET agents offering high sensitivity and specificity, much better to the conventional ectreotyte scan. And honestly, the costs are somewhat comparable. However, insurance companies have not allowed us to use it because the copay is so high. None of our patients at Mercy are able to afford it. Well, thank you very much for your attention, and let me know if you like this lecture format.